I'm Dr. Monty Pal from City of Hope, and this is On the Edge of Breakthrough, Voices of Cancer Research. Each episode, we bring you the minds behind the science, the stories behind the data, and the breakthroughs that could change everything. Let's dive in. Welcome back, everyone, to On the Edge of Breakthrough, Voices of Cancer Research. I can't tell you how excited I am today to have with me Dr. Lee Jones. Lee, welcome to the show.
Thank you so much. It's great to be here.
Now, we just recruited you from Sloan Kettering. We're on the heels of that, and that's huge news, but I think there might even be bigger news, and that is that Oasis is back, right? I mean, this is huge. When we met a couple of times ahead of this, I think that was the main topic of conversation.
Well, that's how we bonded, over English Britpop music.
I love it. And that's actually probably a great way to kind of take us to the start. So obviously your roots are not here in the US. Tell us about your origin story.
Yeah, so I was born and raised in a city called Stoke-on-Trent, which is right in between Birmingham and Manchester.
Okay.
It's the West Midlands in the UK. So that's a city that was dominated by two industries, which was coal mining and pottery. So that's where all like Wedgwood pottery comes from, Rural Dalton pottery, if you've ever heard of.
Of course,
that.
Yeah.
So I was born about 5 minutes away from the factory, and so my dad's side of the family all were miners. My mum's side were all in what we call the pottery industry, the pots. Academics wasn't really a thing. What I wanted to be was a professional soccer player, football player, because that's what you do, growing up in the North. And then when Oasis came on the scene, I wanted to be a pop singer, a rock star. So those things didn't quite work out. So I turned to academics and so ended up going to university. I was there for 3 years, did my undergrad in exercise science. Then after that, I moved back home and just started working, doing local jobs. There's not many jobs that you can get with an exercise science degree. I thought this is where I'm going to be. It's where all my family is. I was working in this job and I just got talking to this guy and he's like, so what are you doing? I'm like, well, I'm just doing my job. And he's like, no, what are you doing here? And I'm like, what do you mean? He's like, is this it for you? Didn't you strive to do something else? I'm like, well, I've always interested in doing my graduate degrees, my master's degree. He's like, so why don't you? So this kind of stuck with me. And long story short, there had been a professor who came over to my university in Brighton who was in Canada. It always said to me, if you ever want to do your master's degree, just let me know.
Okay.
So literally, I went home that night, called, and said, you probably don't remember me, but you said this one time. She's like, oh, Lee, how are you? Are you interested in doing your master's degree? I'm like, yeah. They're like, okay. This was July. You're like, well, you can start in September. So I remember we live in a relatively small house. I walked downstairs. I said to my mum and dad, I'm like, I think I'm going to Canada. And my dad's like, yes. My mum just went white. Okay. Anyway, I ended up moving to this place called Thunder Bay, which not many people have heard of. It's Northwest Ontario. It's a 14-hour drive from Toronto.
Wow.
So I went there to do my master's degree in kinesiology. And quite honestly, didn't really learn too much. I remember getting on the plane and I'm just like, what have I done? Because the professor I knew who told me to come across was doing a sabbatical in the UK, so I knew nobody. The first few days was pretty rough. And then I started to teach the soccer class.
Okay.
Of course, you got the Brit who comes across, they teach the soccer class, of course. There's a person who was also working with me. He was a local fella and of Italian origin. He's like, what do you do? Why don't you come live with my family? So they took me in. I ended up living with his family and we've been kind of friends. They kind of looked after me.
Okay.
And so I was there for 2 years. And after that, I had two choices. I either go back to the UK with this master's degree in kinesiology that probably nobody will recognize, or I could do my PhD. So I'd applied to a bunch of PhD courses in the US as well as in Canada and got rejected from every single one. But I hadn't heard from one place. And this was the University of Alberta in Edmonton. So I called and said, I know I'm not in, but I just want to confirm before I book my ticket back to the UK. And they're like, oh, you haven't got your letter? I'm like, no. They're like, well, you've been accepted. And I'm like, no, this is Lee Jones. They're like, no, you've been accepted. But by this new professor, Kerry Kernier. Now, this will become extremely relevant because Kerry Kernier was the first author on the New England paper.
Wow, what a small world. Okay.
So Kerry accepted me. So, I went from a city of 50,000 people to a city of 1 million people. So it felt like, this is fantastic. University of Alberta is a huge school, 30,000 undergrad.
Right.
So I went there and, got a bachelor pad, started my PhD, was playing soccer as well for the university team at the same time. So I was traveling, trying to balance both. And then Kerry just got his first NIH grant in exercising cancer, colorectal cancer, as it happened.
Okay.
And so it was the PhD student working on that project. So I'd be the exercise physiologist, I'd be the clinical research coordinator. That was my training. I'd be over at the cancer center basically in the labs, in the consults with the oncologists, and this is where I learned oncology. I was there for 4 years, did my PhD there. There was no jobs at that time, so I stayed on, did my postdoc. That's when I started kind of developing my own research interest. I got offered a job at McGill or at Duke. And so I was married at that time as well. I got married to a Canadian lady, which was great. And I said, well, I had to go to McGill where I had this tenure track position, but I had to do some teaching. I knew I didn't want to teach. Or I could go to Duke. I have this basically a 3-year contract. And by the end of that 3 years, I had to be 100% funded from grants. But I'm like, well, 3 years at Duke, that wouldn't look bad on my resume. So we decided to go to Duke. So we drove down from Edmonton to North Carolina. We left on Boxing Day, so December 26th in Edmonton, it was minus 26.
Uh-huh.
And then we were golfing in North Carolina on New Year's Day.
My gosh.
Just unbelievable.
Yeah.
So that was my first job, assistant professor in medical oncology.
And you stayed there for a while, right? I understand you went through associate as well at Duke.
Yeah, the first year was a little bit rough, to be honest. I knew everybody, and Duke was a little bit different, at first at least. But then I got my first grants, started to build my team, got our first R01s. And so, I was there in the end for, I think, nine years or so. Okay. And then towards the end of that, we looked at a couple of different places, and Memorial Sloan Kettering came knocking. And in my gut, it was just the right place to go. So we made the move to New York City, and I completely rebuilt the team. And
you've just been so prolific in the space of exercise oncology. At a time, I think, when there might have been a lot of sort of skepticism, around the field. Tell me about what it was like to sort of build that program at Sloan Kettering, because I imagine, we're going to see a bit of a transformation in our program here with you being on faculty.
Yeah, it was very interesting. I was being recruited there just as Jose Basalga had started.
Oh, okay.
With Jose, and I was just... this guy was just a force. I mean,
just for our audience, a storied figure in breast cancer research, right? And who was really an emerging leader and really had a tragic early passing, right?
Yeah, he did. So there was Jose there. There's Craig Thompson. There was Cliff Hudis, Larry Norton, Howard Scher. And I felt that this was really an important step for me. I felt that I needed to go to a place that would really challenge me, and I want to be in a room where people are skeptical about what we do, and because I think that's what forces you to go to the next level.
Sure.
Cliff would run the breast medical oncology rounds every Thursday morning. There'd be 26 breast medical oncologists in the room. I get up and present, and there'd be like, what about this? I'm like, this is exactly what we need, right? It's exactly what it forces us to think differently and not to rest on our laurels and really push it.
And can I ask, is it fair for me to say that a lot of our understanding of the role of exercise in oncology kind of begins in breast cancer? Is that sort of where it has its roots, or is it more diffuse than that?
Yeah, I think that's where still 80% of all the research occurs is in breast cancer. There's probably a few reasons for that, right? It's a large population. I think it's a population that are very, they advocate for many different things. And I think where really exercise really came to the fore was with the development of cancer survivorship. I think Institute of Medicine report was talking about, the growing survivorship population in oncology, and all the late events that these individuals were experiencing, which a large proportion of those individuals were breast cancer survivors.
Right.
So exercise coming in to be an intervention to address some of the psychosocial as well as the physiological late effects of therapy, that's where it kind of really found its home. So that's where a lot of the research started. And then slowly has been moving out into other solid tumors, a little bit into hematology as well. And so I think for us, that's where we had a lot of our grants. We, really were interested in the physiological consequences of breast cancer therapy, particularly because the role of anthracyclines and Herceptin. Mm-hmm. So when I was in Edmonton, I didn't know it at the time. I didn't appreciate it at the time, but there was a large randomized trial underway looking at adjuvant Herceptin in HER2 positive breast cancer, BCIRG 006. Mm-hmm. There was 3 large randomized controlled trials. BCIRG was run by Dennis Slayman. Mm-hmm. Little known, but the clinical trial unit there was run out of Edmonton. So
you're kidding. So I'll tell you what a small world this is. I actually trained in Dennis Slayman's lab at UCLA.
Yeah. So
right.
Yeah. So Trio was at its offices in Edmonton and was headed up by a guy called John Mackey. Mm-hmm. John Mackey was the head of breast medicine oncology at the Cross Cancer Institute. So I'd be going across to the Cross Cancer Institute, recruiting individuals for Dr. Kernier's studies, but I'd be going to rounds, and I got to know John and all his fellows very well.
Wow. Okay.
So I remember it vividly. We were sitting in a room and he was talking about BCRG. He was talking about 006, and he was like, well, there's a concern because the combination of anthracyclines with Herceptin, in the metastatic trial that was with this New England paper with Slayman as first author, I think the heart failure rate was something like 30%, mm-hmm. something crazy. So people were really worried about this going into the adjuvant setting. These individuals are going to live, longer. And so there was, as a result of that, there was serial echo cardiac imaging that would occur. And we just got talking, John was saying, we're doing this cardiac imaging. I'm like, okay, are you doing anything else to look at, overall cardiovascular, cardiopulmonary health of these individuals? He's like, no, but John is just an amazing guy. He's like, but what are you thinking? I'm like, well, maybe we could do some exercise testing, cardiopulmonary exercise testing, maybe do some exercise echo to really get a better understanding of what might be going on to the hearts of these ladies. Because, if you just look at resting EF, it's, by the time you see a reduction in ejection fraction, in some regards, it's already too late.
Absolutely.
So he's like, okay, well, let's do it. And we got funding from Roche to do like the first exercise echoes in a population of women who were in 006. So we had individuals who were just getting AC or ACT, individuals who were getting just ACH, and then ACTH. And so we would be able to profile them. And of course, what we found is the cardiovascular risk profile, the patients getting Herceptin with the anthracyclines was worse than in the other 2 arms. So the first paper to come out of 006 is our little paper in Cancer Epidemiology, Biomarkers and Prevention, and then the New England paper came out. So that's kind of where it all started for me, was that study.
That's remarkable. So I have to tell you, and this is a little bit of oncology lore at this point, perhaps, but I just remember those initial studies. Dennis Slayman walked into a lab meeting when BCIRG 006 came out and was so excited about sharing with us in a small room the results, right? Hot off the press. But I do remember the debate that emerged from this around use of anthracyclines with trastuzumab and the different camps. It was almost an East Coast West Coast difference in philosophy, where on the East Coast, for instance, folks like Cliff Hudis and Larry Norton were arguing, again, for use of anthracyclines in combination with trastuzumab. On the West Coast, you've got folks like Dennis and others really arguing for docetaxel and paclitaxel-based regimens, right?
Yeah, non-anthracycline. I think in that trial, I think there was a slight, disease-free survival benefit of ACTH, but I would agree with Slayman that was offset by the increase of cardiotoxicity. But of course, it wasn't powered to directly look at that comparison. I think that's what the New England paper said. So it was kind of left out there. But I think as history is continued, I think there's less and less use of anthracyclines in that setting. I think that makes absolute sense.
So this kind of takes me to the studies that you've sort of built, not so much to sort of dovetail on existing trials, but really independent studies that you've designed assessing exercise oncology, right? Exercise physiology, as a means of maybe improving cancer outcomes. I've read some of your studies in the context of not just breast, but prostate cancer. Give us a sense of your philosophy around why we need studies that are specifically evaluating exercise as an anti-cancer strategy.
Yeah, I guess the context there is what I just mentioned with starting in 006 and looking at more of the cardiovascular physiological consequences. So, that's the first half of my career was focused on that very question. And as we were doing more and more work in that arena, we'd have individuals into our trials and they'd say, Lee, I'm feeling better, but what's happened to my cancer? And I'm like, what do you mean? Like, well, I'm fitter now, so that means there's a less chance of my cancer coming back. Does this mean that I'm going to respond better to the therapy I'm getting? And I'm like, I don't know.
Okay, sure.
We don't know. Nobody's really thought about it from that perspective. It's really been from symptom control perspective. So this is right around the time when I'm leaving Duke to go to MSK.
Okay.
I decided that time that, if we're putting together this exercise oncology program, we really needed two arms. We needed to continue our work in what we've been doing and focus on the physiological consequences. I recruited an investigator from NASA to kind of take over that side of the program.
From NASA?
Yeah.
Okay. Tell me about that.
Well, there's a long story there because she is Canadian and she was an intern in Kerry's lab, but basically, helped me get, photocopy.
Fair enough.
So we have a long history. She went from Edmonton, where she was doing undergrad, to UBC to a master's and PhD, and then went to NASA to work on basically the physiological consequences program.
Okay.
So a mandated strategy for all astronauts going to space is exercise. They exercise them in space.
I see the connection now. Okay.
So this might sound a little bit strange, but a lot of the consequences of zero gravity are very similar to the physiological consequences that occur in individuals going through cancer therapy.
I would have never drawn those two together.
Yeah, it's uncanny. Actually, we published a paper. I'll send you the review on this. That did the comparison. I actually think it's pretty fascinating how it was recognized very early in the first NASA flights in the 60s that the physiological consequences was something they needed to address. So they first characterized it, then they started to intervene. And this is right at the same time that we're coming up with the first polychemotherapies. And of course, we recognize the physiological consequences very early, but in oncology, for whatever reason, we didn't try to intervene to stop that. Right? The way that we intervened is by doing dose reduction or therapy discontinuation.
Sure.
A very different approach. So we kind of paralleled like what happened with NASA and then what happened with oncology. And can we now learn from how NASA thinks about basically prehab, habilitation, and then rehabilitation? Because as soon as astronauts know they're going on a mission, they will start training them to get them as fit as possible before they go on the mission. They then train them during space. And then as soon as they come back down to Earth, they're training. And they train them until they reach their pre-flight physiologic status. Okay. Imagine if we applied that model to oncology. Anyway, I digress a little bit, but I was thinking about those kind of questions, and then the patients coming up to us and asking us questions. So when I went to MSK, I'm like, we made the decision we're also going to create this new arm of our program, which for me was like starting again. Mm-hmm. I've got a background in exercise physiology, but I don't have a background in, cell biology. I don't have a background really in oncology per se, other than what I picked up from medical oncologists.
Sure.
So it really, for me, I really needed to think about this. And the way I thought about it is, I think it was hanging around with, again, the medical oncologists, and particularly with John Mackey and others, developing these clinical trials. And I'm like, well, I think that's what we need to do. From an exercise perspective, we need to think about the development of exercise like we would the development of a drug. Mm-hmm. And so the first thing I try to do when entering new areas is try to put like a framework together rather than just, going straight in and try and do these trials that could be a little bit haphazard. What is the philosophy? What is the conceptual model that we're working along to try and develop these questions? So I felt that we needed like a drug development pipeline. So when we started this area of research, this was in earnest back in 2015, the first thing is published this translational framework. And so, going from epidemiologic studies into preclinical studies into phase 1 type studies. Now, phase 1 studies have ever never been done with exercise in any clinical population, let alone oncology. But I felt, I think time and time again, we see trials of things like metformin or vitamin D or omega-3. We see these big phase 3 trials, looking at risk of recurrence.
Right.
And what typically happen? They fail.
They fail.
They fail.
Absolutely.
So why is this? Is this because they don't work? Is this because the trial design has been suboptimal in some way? Is it because we don't know the right population? We don't know the right dose? And so if you look at all these trials, they've basically been designed on the basis of epidemiologic findings, which I don't, given self-report and other, I don't think you can use that information to then design a clinical trial. You would never do that with a drug, right? You wouldn't ask individuals what they've been taking and then say, well, okay, based on that, we think we should, this is what. No, you'd follow a very rigorous approach. So we basically tried to do the same thing. So that's where it came from. And, I live in the oncology world. And so, our research looking at the physiological consequences, I think that's going to move the needle a little bit. But I think to really make this part and parcel of standard of care therapy, then we need to be designing trials with the same endpoints as the oncologists do. We need to speak the same language.
You need to look at recurrence, overall survival, all these...
PCR, overall survival, relapse rate, because that's the world in which I live. And I think if we really want to get oncologists on board, then they're the kind of studies that we need. And, we need to be publishing in New England and these others. And then you read that side by side and you say, okay, that's the evidence we need. It's not the evidence that's going to convince me. It's the evidence we need to convince you.
Sure.
So that's really where we came from. And that's the way that we've tried to approach it.
Brilliant. Speaking of New England, you brought it up. So, this challenge study that was just published there, huge waves in the oncology world. It was one of the highlighted presentations at our ASCO meeting this past year. It was led by, I didn't realize this prior to discussion today, your former mentor, Kerry Counier.
Yeah.
Excellent study. Would love to get kind of your take on it. And just in case our audience isn't familiar, maybe you could sort of spell out the design a little bit and some of the primary results.
Yeah, so the challenge trial was basically designed back in 2007, 2008.
Wow.
And it was designed on the basis of 2 epidemiologic studies, both published by Jeff Meyerhart, actually in the same issue of the JCO in 2006. So Jeff had I think they got data from a randomized trial where they collected self-reported exercise. So Jeff come along and said, well, let's look at the association between how much exercise these individuals were reporting and the risk of colorectal cancer mortality. Mm-hmm. These were in sample sizes of like 600 and maybe 800 individuals.
Okay.
So these are not huge epidemiologic studies, but they found a hit. They found an association of individuals who were reporting around about 18 MET hours of exercise a week. 18 MET hours of exercise a week is about 300 minutes of moderate intensity exercise a week.
Okay.
So an hour a day,
Got it. Okay, I'm just doing the math in my head. Okay, got it.
Any exercise levels, doses below that weren't associated with colorectal cancer, colorectal mortality. And then interestingly, if you went above that, it was kind of a plateau. Okay. It wasn't a dose response. So there was 2 epidemiologic studies. So on the basis of that, what do people say? The associations, it was like a 40% reduction in the risk of dying from colorectal cancer after controlling for things like BMI, stage of disease treatment. So people say, well, that's an association. The observational data is the weakest form of evidence we have. It's not causal. So the only way we're going to actually prove that exercise does have a mortality benefit is to do a phase 3 randomized controlled trial. In my view, that's a colossal leap, right? You're going from these epidemiologic studies to now designing these phase 3 trials, which is exactly what we've been doing for things like metformin, omega-3s, every vitamin, vegetable intake. And again, they've typically failed. So, they were doing the same thing. So the challenge trial was, the primary endpoint was disease-free survival. I think the original design was almost 1,000 stage 2, stage 3 colorectal cancer patients. And this is, I guess I look at this as extended adjuvant therapy, because all these individuals had to finish their primary definitive therapy, and then it was randomization to exercise or not for a period of 3 years. Now, so it was a control group. They got health education, which was basically some physical activity advice. And then in the intervention group, basically they got supervised exercise for the first, I think it's like, correct me if I'm wrong, I think it was the first 3 to 6 months. And after that, it was a home-based program.
That's my understanding too.
And so what did the data show? Well, there was disease-free survival benefit, significant, and an overall survival benefit. And, I think in the region of 30% improvement, I think, in DFS. I think similarly with overall survival. And, quite honestly, I was surprised. I've got to be honest. I was expecting it to be negative.
Okay.
On the whole, I think for the field, it's been a huge job. I mean, the coverage that it's got has just been incredible. I was getting text messages from all over the planet. Just like
I think I was one of those.
Yeah, I mean,
to get your take
just
on
like, it. Look at this data. This is phenomenal. So I was very eager to read the paper.
And I will say that in our discussions, you brought up a couple, and this is important in any, sort of academic setting, to have really sort of a healthy debate around some of the fine points of the trial. One of the things that we sort of touched on in our discourse was sort of the duration of accrual, right? 15 years, is that right, to really get the study from start to finish? Yeah,
and I think this is a problem that we have with behavioral trials, right? Mm-hmm. So the way this is originally designed is, because of the supervision aspect, then in the sample size required and the length of intervention, then you can only recruit from sites that have the ability to be able to administer exercise at high fidelity, let's say.
Right.
And so in colorectal cancer, historically, those trials with exercise have been hard to recruit to. So, and I think this was reflected here. It was a long duration. I know it was a tough slog. And I think it got a standing ovation at ASCO. I think more, as much as for the results as for the persistence.
Yeah.
But of course, that raises some issues, of course, because, standard of therapy can change a lot during that time.
Absolutely.
They defended in the paper said didn't change that much, and maybe they were fortunate to get away with that. But of course, the outcomes in the control group were better than expected, but that's going to happen over a 15-year period. Outcomes are going to get better. So that tells you that type of approach, people might say, well, you don't need to do supervision, everything can be home-based. But I think that also raises question about delivery and quantification of the actual exercise intervention itself, which I think is something that's we don't talk about enough.
And that, if I recall correctly, was really based on self-report in many cases in this study, which I think probably comes with its own caveats.
Yeah, exactly. So I think there was an important caveat. It said in the paper that they recruited non-exercising individuals. And I think this is a really important point, because if you think about eligibility for a drug trial, then typically individuals coming to drug trial have had no prior exposure to that drug. Right. And in fact, if they've had prior exposure to any drug that we think even might be related, they're typically ineligible, right? Because can we really interpret, the new administration of this drug on disease endpoints? And in this case, so what we've tried to do is try to recruit non-exercising individuals. If individuals are already exercising, they're already taking the drug, that's particularly problematic in a randomized trial. If they get randomized to a control group, now you've got contamination.
Exactly.
So the differences between the intervention, the experimental, and the control group are minimized. So what happened here? So they said they recruited non-exercising individuals, but the mean MET value of exercise at baseline was something like 11.5 METs. 9 MET hours a week is 150 minutes.
Okay.
So these individuals were already doing the CDC guidelines at baseline.
Got it.
You've got a very active population coming into this study. They went into, either the control or the exercise group. And the goal of the exercise group was, you have to look at this a little bit differently, because the goal was to increase the amount of exercise by 10 MET hours above what they were doing at baseline. So so I think people look at this and say, well, the intervention, it was only like you had to do 3 to 5 days a week, about 45 minutes. No, it was that on top of what they were already doing.
Right.
Basically double the amount.
Okay.
And so what happened, the control group was still reporting, actually they increased their exercise behavior a little bit actually across the course of the study. So they were exercising consistently throughout the study, the control group, but the exercise group was doing more.
Okay.
And so I don't think this was a comparison of a sedentary versus exercise group. I think it's different levels of exercise. And you're right, there was a supervised portion, but adherence to that supervised portion was actually poor. And then it was self-reported compliance to the exercise intervention. But the exercise intervention was also reported as individuals were able to do any dose, any modality, any intensity that they wanted to do. And they got, and again, it worked, right? Mm-hmm. But again, if you think about that from a drug context, imagine you doing a randomized trial where you said, well, you can take any amount of the drug that you want, over above the amount that you're already taking. So I think, there's some caveats that come along with that. And so I think this was a case of an intervention that tested a higher level of exercise relative to a group that was already quite active to begin with.
I'll tell you, I think the challenge study, which as you'd mentioned has gotten so much press, does have those flaws. And it actually, in some ways, leads into, I think, some of the benefits in the testing strategies that you've devised for exercise oncology. I've had a chance to read through several of your papers, and I've got a flavor for the methods of administration of your studies, the sort of the tested hypotheses and so forth. Maybe this is a good opportunity for you to sort of dive in and tell us how we can sort of ameliorate some of these issues that studies like Challenge suffer from.
I completely agree with you. I think the debate is a healthy debate. I think we should be debating these studies just as much as we would a drug study. I know there's when it comes to exercise or diet, people are like, well, these are so good. But no, I think the only way we can get better, right, is to really critique these studies in the way that we would critique any study. So I think it's healthy to do that. And I think my view of every trial has limitations. There's no such thing as a perfect trial. So I think despite some of these caveats, it was a positive study. So I look at this and say, well, imagine if we were able to address some of these limitations, maybe the benefit is even better than,
Agreed.
What we've tried to do is, again, really adopt that drug development approach and try to understand, I think, key prerequisites to basically do the optimal study design. So when we get to a phase 2 definitive trial, we know what the dose of exercise should be. We know what the duration should be. We know what the schedule is. We know what the right patient population is. And I think we have a mechanistic understanding of how it might be working. So that's what we tried to do. And again, we can glean some of this information from observational studies. It's not perfect, but we can start there. We can obviously get into our mouse studies, which of course have their limitations as well, but we can start looking at dose response. And I think we and others have started to tick some of those boxes. And so where I felt where we needed to go is to do these kind of like phase 1 equivalent type trials.
Yeah.
Because we need to first, I think, have an anti-tumor biological signal for exercise. Before we would design a trial on a hard endpoint like PFS, DFS, or PCR, we first need some indication that exercise has any anti-tumor efficacy at all in a human, right?
Well,
a signal.
I wonder if maybe we can discuss this in the context of one of your published reports. I mean, I'm thinking about your JAMA Oncology paper looking at prostate cancer, and I saw that title incorporating the term phase 1, and I really read it with a lot of interest. So maybe you can tell me a little bit about how that study in particular was structured.
Yeah, so there'd been a few epidemiologic studies looking at the relationship between post-diagnosis exercise and risk of prostate cancer mortality, and showing a benefit, a pretty significant benefit. But again, same kind of thing with colorectal cancer. It's observational. Where do we go from there? And I didn't feel that we should make that leap and do a phase 3 trial. I'll just mention the caveat there. There was a phase 3 trial that was launched called I think it was called the interval trial, which was a phase 3 trial of exercise and resistance training in men with metastatic castrate-resistant prostate cancer.
Okay.
But that closed early due to lack of accrual.
Interesting. Okay,
Anyway,
I didn't know that.
So that was going on in parallel, and we thought that study came to MSK and said, "Do you want to be part?" I'm like, "I don't think we're ready for that."
Yeah.
So we decided to take the slower approach, if you will. So we had some preclinical data suggesting also there might be a signal, and so I felt there was a decent rationale of why we should launch a phase 1 trial in localized prostate cancer, and so I'm like, if we're going to design a phase 2 trial, again, what was the dose that we should be using? Should we even do a phase 2 trial? What if there's no signal at all? Then why should we even do a trial in the first place? That that would be the no-go decision, right? You'd stop the development. If that was a drug, you stop it right there, right?
Right.
You do a phase 1. If it's not safe, if it's toxic, you stop. If there's no signal, you stop.
Yeah.
So we go into these studies with the same kind of mindset. And so, I thought prostate cancer had a good biological rationale of why we were going there. And then we need to get to the tumor, right, to look at anti-tumor activity. Once you apply that filter, there's only certain settings in which you can do that on an oncology, because most of the time it's either getting neoadjuvant therapy, so it would be confounded by the effects of other anti-cancer therapy, or it's in the adjuvant setting where there's no tumor to assess. You can use ctDNA, but I'm not sure it's quite ready for prime time.
Yeah.
So, we looked in. We thought maybe these preoperative window of opportunity studies might be a setting in which we could do this. So, I spoke to some of the surgeons at MSK, and I'm like, what window can you give me? And they're like, well, probably 3 to 5 weeks. I'm like, done. Let's do it. Let's do it. So the idea was that we would take these men, non-exercising men, all scheduled for their radical prostatectomy, and we would exercise them in the window. We would exercise them from the point of diagnosis until their scheduled surgery. We wouldn't delay surgery in any way at all.
Okay.
So we just used that window that they had.
Okay.
Does this make sense?
Yeah, absolutely. Kind of your classic window of opportunity study, if you will.
Precisely.
And we do this in drug design all the time.
Yeah. The idea was that within that window, we can look at escalated doses. Mm-hmm. So we thought, maybe we can use, a 3+1 design, So I started reading about phase 1 trial designs. If you know Dave Hyman.
I know David. Yeah, absolutely. Terrific drug developer, actually.
Oh, yeah, exactly.
A lot of huge phase 1 trials.
Exactly. So Dave is the first person I went to and said, hey, I'm thinking about this study, and why not, kind of thing. And so once I decided, okay, these are how we think we're going to design the trial. If we are looking at these escalated doses, it went from 90 to 450 minutes of exercise per week.
450 minutes of exercise per week. Wow. Yeah. Okay.
In sedentary individuals.
Doing the math in my head, so that's about an hour or so a day ish.
Yeah.
Yeah. Hour and change. Okay.
So I thought, well, we've got a problem, right? Yeah. So think about the classic model in which we would do these studies. We would bring people into our fitness facility. And I'm like, so what we're going to have to do, we're going to have men who live close enough that they can come in 5 days a week. Because, we're not doing now just 3 days a week for 30 minutes.
Right.
If we're dosing people at 200, 300, 375, that means they've got to come in, right? And so I knew that was going to kill it. It would kill our ability to do phase 1 trials, because if you look at probably 90% of all exercise interventions on oncology and beyond, they're typically 12 to 15 weeks, 3 days a week for 45 minutes at a time, right? The exercise intervention is typically the same in every single exercise trial.
Right.
So why is that?
I'm not sure.
So is that because we believe that's the optimal dose that has the effect on, fitness and quality of life? Well, I don't think that's the case. I think it's the case because that's what research believe that participants will be willing to do.
Okay.
If you extend it longer than that, patients will drop out.
Okay.
If you say we want to train you 5 days a week, patients won't enroll in the first place.
And it has nothing to do with establishing a behavior, does it? I mean, they won't carry on with this program beyond that necessarily.
You want to deliver exercise at high fidelity because you want to test the effect of dose A on outcome B, right? So you want to deliver that at high compliance.
Okay.
So this is why we use a supervised setting, because we could bring people in and we could watch them exercise.
I see.
Versus using an approach where they go home or they exercise at home and you don't know what they're doing.
Right.
So they might report that they're doing something, but you actually don't know.
Sure.
And the other problem with that is, what if, something happens during the session? You wouldn't know anything about it until after the fact.
Okay.
We found that when we are doing real-time dose modifications because blood pressure is too high, heart rate's too high, so we want to intervene on the spot. That to us is an event, and so we would, so we can precisely quantify exactly what the individual did. We know what we want them to do, but we know exactly what they did. So then we can calculate RDI.
Okay.
For each exercise session. So knowing that the classic supervised approach wasn't going to work, I'm like, we need to develop a completely new way to think about this. So I thought about, well, maybe we could partner with gyms and areas and, but then I'm like, that's just not going to work because one, I don't really want our participants going to this gym. I've got to have a staff member in every single gym. Yeah. This has got to be covered from 7 in the morning till 7 at night. Like, we're going to be bankrupt. So I think I was running in Central Park, just thinking about this a lot. And so I felt that the only way we were going to do this is if we ship treadmills to the patient's house.
So this is actually where it gets pretty wild, in my opinion. This is just such an interesting, innovative concept. You got to tell us how that worked out.
It took a while. So this is pre-COVID.
Uh-huh.
So I thought, well, this is what we need to do. So we need to get these treadmills to these patients' houses. And, that's step one. So we need to partner with a company that's going to be willing to do that. White glove service, deliver the treadmill, set it up, but also then extract the treadmill.
Yeah. I have to confess, I've had exercise machines in boxes in my house for a long time.
So we had to find a treadmill that wasn't too big, but also if you put an iPad on it, it didn't shake too much. Okay. It was at the right angle. So literally we were going down to Soho I'm not making this up, my team and I went down to Soho and we're going to all these different places like commercial vendors, Techno Gym and others, to actually go on the treadmill and test these out. So we put an iPad on there and I'd run on it and we do all this and this is before Zoom was a thing. I think we purchased 10 treadmills just to give this a go. And, some of my staff lived in New Jersey, so we shipped a treadmill to their house and, first make sure that the connection was solid and it worked out. So we got that piece going. This is before the trial launched, of course. So we were beta testing. And then I'm like, wait a second, if we've got an iPad on these individuals and we're watching, what other devices could we also send to these individuals to now track other things that might be going on? So once I started thinking like that, I'm like, oh, okay, this is going to be phenomenal. So we ended up, thinking about, okay, getting a smartwatch to them. Now we can track heart rate every 5 minutes. We can track their sleep. We can track their mobility. We sent them a scale so we can get body composition every day. I'm like, okay, we can get them a glucose monitor. So we put a glucose monitor on the back of the arm.
Okay.
So we can, now I'm like, oh, that's now a biomarker. It's a readout that we're getting. Obviously blood pressure every day as well. And so what I started thinking about is, yes, we're testing exercise, but now we're also able to collect all this other lifestyle related information that's, because we know what they're doing for that hour that they're with us exercising, but what's going on for the other 23 hours?
Yeah.
If they're now exercising less, moving less, that's going to impact the trial. If they're eating differently, these are all the confounders that we have in all trials, but we never measure them.
Right.
So I thought this was an opportunity now we can go all in and start collecting all this data. And then the next level of that was, okay, well, if that's now doing this digitized, decentralized approach, the entire trial should be digitized. No paper, no nothing. Everything should be electronic. The way we contact the physicians to get referrals, way we consent individuals. Even think about consent, you bring people in, you go through a 3-hour consent. I'm like, why are we doing that?
Yeah.
We can do that remotely. So we were the first group at MSK to do remote real-time e-consent.
So this is what sold me, I have to say. When I read through all of your papers and the way that you structure these studies, I thought to myself that, gosh, with this massive transformation that we're having here, right? I was used to the model of trying to do only studies that I could do in my own backyard, 20, 30 patients, folks
right.
that I was seeing myself here at the institution. Now we've got Chicago and Atlanta and Phoenix and Irvine and all these other massive centers that are built around us. The model that you have here, I think, applies perfectly to the type of study that we could do across all those centers, don't you think?
Absolutely. You know, when we had our site-based approach at MSK, we would only recruit individuals who live within an 8-mile radius of MSK.
Okay.
Because that would, like, if we ask individuals who live beyond that to come into Manhattan, you know, 65-70% of individuals at MSK don't live in the city. They live in the tri-state area. So, you know, if you look at, even with that, so we were losing, before the study even started, we're losing 50% of potential eligible individuals because we didn't even consider them.
Right.
And then even with an 8-mile radius, people were saying, we were losing 30% of those because they said, well, it's too inconvenient and it's too far to travel. So once we had this approach, this was decentralized, I'm like, the sky's the limit. Right?
Yeah.
So that's where we started, 100-mile radius. But now we're up to like 350. I mean, now coming here, particularly with multiple sites across the country.
Right.
I mean, we've already been thinking about things in Brazil, right? So I think the sky's the limit. I mean, with this approach, there's no reason we couldn't recruit an individual from anywhere.
I love it. I'm going to shift gears a little bit now and maybe sort of ask about the futurescape here at City of Hope. You know, I think that obviously you've got a ton of brilliant ideas. Where do you imagine your first couple of steps after joining our faculty?
First of all, it's this. I'm so excited to be here. I think when we first met, you were saying this was a bit of a hidden gem, but then you said not so hidden anymore.
Not so hidden anymore, exactly. Yeah.
And I think that was spot on. And you know, just the energy. We've got some things to take care of initially, which is some of our legacy studies that we're bringing over from MSK. We've got 3 of those that we were finishing off. These we've got building on from our localized phase 1 prostate study. We've got a phase 2A study in active surveillance right now with basically a disease progression primary endpoint. So that's now, you know, taking the recommended phase 2 dose that we identified in the phase 1, now testing that in the active surveillance setting over a longer period of time, but now on disease progression.
Got it. Okay.
So that's been the progression, if you will, of that study. So that study's ongoing. That's an R1. It's a phase 2 randomized trial. We need 102 participants. I think we're at like 50 or something like that. So
got it.
It's going well. We've got another study in the adjuvant setting where we're using this was a phase 1A, phase 1B trial. So phase 1A dose finding in the adjuvant setting, looking at both compliance or feasibility, as well as things like peripheral immune response, as well as ctDNA. Mm-hmm. We finished the phase 1A, the dose finding. Now we're doing the phase 1B dose expansion.
And just to clarify, what setting is that? That's in.
This is all in individuals. Initially, it was in breast and colon, but in the phase 1B, I wanted to extend it to any solid tumor post-definitive therapy.
Got it.
And that's, you know, initially that's a 6-month intervention. Mm-hmm. All decentralized. Well, individuals have the option to continue exercising for another 12 months. So it's potentially an 18-month intervention with serial blood collection. And again, our blood collection is all done remotely as well. So individuals don't need to come in to do that blood collection. So we'll do the same thing here. I think I've got 4 R1s that are in the works, so to speak.
My gosh. Okay.
You know, at various stages. We've got a big study in Lynch. Okay. So we just finished this Lynch pilot. So we're very interested in interception in high risk individuals in the prevention setting. Lynch is I think a great setting for that. We just finished a study, 15 individuals, a year of training. We got tissue pre and post. We're doing, you know, single cell RNA-seq on it, as well as the PBMC is doing single cell on that to look at immune infiltration into the tissue. I think we've got some really interesting data there. So now I want to do the next study, again, now a phase 2A powered on events. Okay. So that's that. We also just finished a study in high risk women for breast cancer. So these are BRCA1, BRCA2, high family history. We did a dose finding study. Actually, we did a co-clinical trial, dose finding in individuals at high risk. Then we did the mouse mirror image study.
Interesting. Okay.
Same exercise doses, same duration of exercise.
Okay.
To identify the recommended phase 2 dose. I think we did that. So now we want to do, again, the phase 2A study, which will be a randomized study. So we've got that one in the works. We're writing a grant right now, actually, that will be in basically triple negative breast cancer, getting neoadjuvant chemoimmunotherapy, and we're looking to do that study within I-SPY.
Okay. Oh, great. With Hope, terrific.
Exactly. So that's the idea there. So we're working on that. And then after that, quite honestly, what I would like to do is be a sponge.
Okay.
I want to meet with you more often. I want to come to all the rounds. I want to come to as many research meetings as possible. And I just want to, I want to be a sponge. I want to take it in and I think just learn what people are doing here. And I think that's then going to generate, I think, new ideas. And rather than me coming in and say, well, my path is set. This is what I've got that. But I think that the amazing opportunity here is to come into an environment, learn what people do in innovative approaches, and then see how our work fits into that, or makes us think differently. I mean, again, that to me is the opportunity. This is why I've come here. Is not for me just to do the things that I was going to keep doing at MSK. Is to do something different, right, and really blow it up. And I think, the infrastructure that City of Hope has really, I think, blends very well with the approach that we have. And so, just imagine the studies that we could. I want to like dream big. I want to dream big.
It's so funny because oftentimes you hear about people transitioning institutions, and occasionally, they're very appropriate. They'll take a couple of months off, relax, travel the world and so forth. But what I love about you is that I don't think a week or two has gone by when we haven't exchanged an email or a thought, around what, you're doing and what I'm doing and so forth. And, clearly from our discussion now, you've engaged with Hope Rugo, our, sort of internationally acclaimed breast cancer expert. You're incorporating in her trial I-SPY. This is just all fantastic, and we are just absolutely excited about the possibilities that emerge from having you here.
Yeah, I'm so excited. I think the way I look at it is we've now got this foundation, and now we can the infrastructure, the foundation, some initial data to really go to the next level, and then some. So the sky's the limit. I can't wait to get going. What
we should do, Lee, is let's remember this moment, and 5 years from now, let's do the same podcast together and see how much of this has come to fruition. I have a feeling a lot will, so I'm super excited about that. One of the things that we always sort of close the program by doing is asking our guests a question, and this is a tough one. The title of our podcast is On the Edge of Breakthrough, Voices of Cancer Research. What does On the Edge of Breakthrough mean to you, Lee Jones?
It's a great question, and it is a tough one. I think we're always on the edge of breakthrough. I think we're on the edge of breakthrough all the time. There's not a finish post, right? It's not as though we'll do a trial and say, that's it, we're done. There's always, this is why I love science so much, is because there's always something else. There's always something that we always can do better. I guess what I'm really excited about is I think there's a paradigm shift coming in oncology. In really recognizing the interaction between the environment, the person's physiology, host physiology, the tumor microenvironment, and of course, the cancer cell itself. And I think so for so long we've been focused on the cancer cell, and of course we've moved now to the tumor microenvironment. But I think now cancer doesn't exist in a vacuum, right? It's surrounded by this host that feeds every cell in the body, including cancer cells. So these holistic level interventions and how that blends with an individual's environment, I think that's where we need to go. And so think about the opportunities at that level, the types of data that we now need to collect that we've ignored. But I think the opportunities that creates for us to think differently, the types of data we need to collect, and how that's, I think it really is now, it is a more patient-centric approach. And so the opportunities and the discoveries that we're going to make, us and others, I think, over the next decade are just going to be remarkable. It's going to be remarkable. So I'm very excited about that. So that's the next edge of discovery. That's happening all the time. Every day I go into PubMed, right? There's a new discovery, like, oh, that's so cool. That's so cool. And so this is happening all the time. So that's what edge of discovery means to me. Brilliant.
It's so funny. Folks ask me, what is the most common question you get in the clinic? It's actually not, doc, what drug should I get, right? It's never, the things you might anticipate, how long will I live? These are common questions you would imagine would arise in an oncology clinic. But rather, folks always ask, first and foremost, what should I be eating? The second question that always comes to mind is, what else can I do to enhance my health? And exercise is always a part of that equation. So we are very, very lucky to have you here to help really sort of get at the root of the questions that all of our patients are asking, Lee. Thanks so much for being here.
Yeah, it's my pleasure. And I'll just finish on that. I really see it as my job is to put that data into your hands to inform those kind of discussions. I think, individuals are always very interested in what they can do to impact their own trajectories. And I see it, my job is proving and providing the information to inform those conversations.
Okay, 5 years from now, same time, same place, okay?
You're on.
All right. I'll see you then.
Okay, thanks so much.
Thanks for tuning in to On the Edge of Breakthrough. See you next time for more insights from the front lines of cancer research and care.